All right. Hi, everyone. I'm going to give it about 30 seconds before we begin while people are joining. All right, we're going to go ahead and get started. So here we are again. It is our annual ICD-10-CM 2025 Updates and Regulatory Readiness webinar. My name is Jordan Leibovitz. I'm part of the marketing team here at IMO Health. Before we get started, few housekeeping items. This webinar is being recorded. So a copy of this recording, a copy of the slide deck, and a copy of a certificate of attendance will be included in the follow-up email. So be on the lookout in your email inbox this week. Throughout the session, everyone will be in listen-only mode. So if you have any questions during the webinar, just type them into that Q&A section on the bottom of your Zoom console. And then at the end of the webinar, we will have a Q&A session. And so if for some reason your question isn't addressed, we will address it after the fact. Today, we have three lovely coding experts from IMO Health. June Bronner, she's our Vice President of Global Clinical Services. Teresa Rehanek, she's our mapping informaticist here, and Dr. Julie Glasgow, she's our Senior Staff Clinical Terminologist. So without further ado, I'm going to pass it on over to June.
Great, thank you, Jordan. Welcome, everyone. Here is what we will be reviewing today during the webinar. We will look at additions and revisions of ICD-10-CM within the various body systems, highlight changes to coding guidance, as well as any interesting index and tabular changes. Lastly, we will review IMO Health's ICD-10-CM modifier changes. So let's get started. April 1st of 2024 brought some routine maintenance changes within the alphabetic index and tabular. Primarily, these changes are related to correcting minor spelling errors and updating several excludes one notes to excludes two notes. But there were a couple of corrections in the index for CNS depression to point to code G98.8 and feeling of foreign body and throat, which now points to code R09.A2. As usual, October 1st is still the update with the largest amounts of changes. On average, there are just over 500 new codes implemented for each fiscal year. For fiscal year 2025, this is somewhat of a lighter year for new codes with 252 adds, 36 deletions, and 13 codes with revised titles, as you can see on this slide. On the next slide, we will start digging into these changes, beginning with lymphoma. Lymphoma is a cancer of the lymphatic system, which includes the lymph nodes, spleen, thymus gland, and bone marrow. Lymphoma can affect all of those areas as well as other bodily organs. The primary objective of lymphoma treatment is the eradication of the malignant lymphocytes to achieve complete remission. Complete remission is characterized by the total absence of detectable disease. Many patients entering remission may be entirely cured. There are 65 new codes created for lymphomas classified to C81 through C89 to identify in remission status. For specific types of lymphomas in C86, C88, and C89, new codes were also created to classify lymphoma as not having achieved remission. Not having achieved remission includes lymphomas that have failed remission. A new code C83.390 to specifically classify primary central nervous system lymphoma, or PCNSL, is being added this October. There was a specific code for it in ICD-9-CM, but not in ICD-10-CM at the time it was implemented. PCNSL is an aggressive extranodal form of non-Hodgkin's lymphoma, which originates directly in the brain, meninges, or spinal cord. The PCNSL is a rare disorder compromising about 4 to 6% extranodal lymphomas and 1% of all non-Hodgkin's lymphomas. And there are several cell types which can make up the PCNSL. About 90 to 95% are diffuse large B cell lymphomas. The remaining cell types include lymphoblastic T cell and Burkitt's lymphoma. Next, we will turn our attention to the hormone receptor status code changes. There are 3 key clinical biomarkers in the workup and treatment of breast cancer. These include estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, or HER2. These receptors can be negative or positive. Hormone receptors are proteins that bind to specific hormones like estrogen or progesterone. These receptors are found on the surface of breast cancer cells. If the cancer is hormone receptor positive, then it can be treated with hormone or endocrine therapy. If the cancer is hormone receptor negative, then hormone or endocrine therapy is rarely effective. HER2 is not a hormone, but a protein that is normally found on breast cells that is involved in natural cell growth. HER2 can become overexpressed in breast cancer, and there are drugs to target the HER2 protein. All 3 of these biomarkers are used to determine the prognosis and predict the course of breast cancer and aid in selecting the most effective therapies for treatment. Triple-negative breast cancer accounts for 10 to 20% of all breast cancers. This is a particularly aggressive type of breast cancer and likely to reoccur. As many of you may be aware of, ICD-10-CM only has unique codes to capture estrogen receptor status. New codes are being implemented to capture the progesterone receptor, HER2, and triple-negative breast cancer. When assigning these codes, watch for the tabular instructions. There are notes to use one code as available for each receptor status unless a combined receptor status is documented. If a combined receptor status is documented, then a code from Z17.4 is assigned. For example, carcinoma of breast, estrogen and progesterone receptor negative, HER2 protein negative would have 2 codes. C50.919 for the malignant neoplasm of the breast and Z17.421 for the hormone receptor negative along with the HER2 negative status. Next, we'll see and look at the blood disorder changes. Fanconi's anemia is a genetic disorder characterized by progressive bone marrow failure, congenital malformations, and an increased risk for malignancy. 80% of patients with Fanconi's anemia develop severe bone marrow failure that may be fatal before the age of 10. Allogeneic hematopoietic stem cell transplant is the only curative treatment for the hematological manifestation of Fanconi's anemia, which is a rare disorder. Another blood-related change is the addition of codes for Duffy's phenotype. Duffy is a minor red blood cell antigen, which is analogous to the major blood types or Rh status, and there is a known association of the Duffy null phenotype with a lower range for the absolute neutrophil count or ANC. Individuals with Duffy null status typically fall outside of the U.S. established normal neutrophil count reference ranges. The ability to classify Duffy phenotype will allow for accurate documentation related to this finding and help to prevent unnecessary further testing in an individual with Duffy null phenotype. Turning our attention to endocrine changes, type 1 diabetes results from a chronic autoimmune destruction of insulin-producing pancreatic beta cells that long predates the onset of symptoms. And insights from various prospective longitudinal studies have shown there are distinct identifiable stages prior to the onset of symptoms. Clinically symptomatic onset is preceded by a period of isolate autoimmunity with one or more autoantibodies against the isolate autoantigens. Persistence of multiple isolate autoantibodies predicts the progression to symptomatic type 1 diabetes. Studies have shown individuals with asymptomatic dysglycemia are at a very high risk to develop symptomatic type 1 diabetes within the next 5 years. 3 new codes have been introduced to capture the stages of pre-symptomatic type 1 diabetes. As you can see on the slide, the stages are defined as follows. Stage 1, the multiple isolate and autoantibodies with normal plasma glucose, and the individuals are pre-symptomatic. Stage 2, isolate autoantibodies with abnormal glucose tolerance, also pre-symptomatic. Stage 3, plasma glucose levels are above the American Diabetic Association diagnostic threshold. These individuals typically are symptomatic, and they are currently at this stage captured at E10.9 with type 1 diabetes mellitus without complication. Also note the new guideline on the slide for when to assign these codes. Hypoglycemia codes have changes for this October, as we will see on the next slide. There are 3 individual levels of hypoglycemia which were developed by the International Hypoglycemia Study Group. This group included representation from several clinical groups and nonprofit organizations, including the American Diabetes Association, Juvenile Diabetes Research Foundation, American Association of Clinical Endocrinologists, and several others. The level system was adopted as a standard of care by the ADA and American Association of Clinical Endocrinologists. This slide provides the criteria that was established for each level. You can also see the corresponding codes created to represent each level in ICD-10-CM. Historically, clinically hypoglycemia has been documented subjectively using mild, moderate, or severe. The level system creates an objective classification, and this system applies to all conditions where hypoglycemia may occur, not just with patients with type 1 and type 2 diabetes. For example, patients with pancreatic carcinoma, patients undergoing chemotherapy, glycogen storage disease, and others also experiencing hypoglycemia, and the level system can be used in conjunction with these conditions. Due to the supplemental nature of these codes, tabular notes have been added to instruct one to use additional code for hypoglycemia levels. Now it is time for our first polling question. The patient presents with type 2 diabetes, currently hypoglycemic. The physician documents the patient has recurrent hypoglycemia consistent with level 2 hypoglycemia. How should this encounter be coded? A, E16.2, B, E16.649, C, E16.649 and E16.2, D, E16.649 and E16.82, and you can see the code descriptors on the slide. Jordan, can you please launch the poll?
For sure. All right, it is launched. So put in your answers. We'll give it a few seconds while everyone submits. All right, June, it's looking like D is taking the lead here.
Great, wonderful. And the result is D is correct. As noted earlier, the new hypoglycemia level codes were created as supplemental codes for a variety of disease states. And next, we will review the new codes for another important but rare neuroendocrine-related condition. Carcinoid heart disease is a rare condition in patients that have neuroendocrine tumors. Patients with neuroendocrine tumors can have functional tumors. A functional tumor means that the tumors are secreting vasoactive substances such as serotonin that can lead to the development of carcinoid heart syndrome. Carcinoid heart syndrome typically develops once the primary neuroendocrine tumor has metastasized to the liver. Carcinoid plaques are deposited on the heart. Initially, carcinoid heart syndrome primarily affects the right heart with degeneration of the pulmonary and tricuspid valves, but can affect all 4 valves of the heart. Eventually, the patient will develop heart failure. And on the screen, you can see the 4 new codes along with the instructional notes that are effective October 1st. Another endocrine-related area with several code changes we are going to review is obesity. Obesity is a chronic disease that is defined by having a BMI greater than or equal to 30 kilogram per square meter. It is often assumed that most causes of obesity are related to lifestyle. However, the underlying cause is often a complex mix of social, psychological, biological, and genetic factors. Monogenic obesity is different from other forms of obesity, such as lifestyle, in that it is a rare and severe early onset form. There are several known genes that play a role in monogenic obesity that are associated with the MC4R pathway. The MC4R gene is a key regulator of energy homeostasis, food intake, and body weight. Mutations within this gene have been associated with childhood onset obesity, hyperphagia, and hyperinsulinemia. E88.82 has been introduced in the metabolic chapter to capture this specific and unique cause of obesity. The index entries on the right-hand side of the slide show you the various specific gene mutations that impact the MC4R pathway and are now classified to code E88.82. Additionally, a new code for genetic susceptibility to obesity has also been introduced. Other obesity-related code changes are codes to capture obesity class, as we will see on the next slide. New obesity class codes have been introduced to classify obesity by these categories with the goal of classifying the severity of the obesity. These new codes help to avoid the use of confusing terminology such as severe or extreme. Additionally, obesity class helps to reduce the use of stigmatizing language such as morbid or excessive calories. Obesity classes have been established for both adults and pediatric age groups as shown here. Adult obesity class codes start at when the BMIs are over 30 kilograms per square meter. The different adult classifications with specific BMI breakdowns are shown on the left-hand side. Obesity in children and adolescents is determined by age and gender-specific percentiles. A pediatric patient may suffer from obesity at a lower BMI than an adult. The pediatric classification recognizes class 1 obesity as a BMI greater than or equal to the 95th percentile to less than 120% of the 95th percentile. Class 2 is a BMI greater than or equal to 120% of the 95th percentile to less than 140% of the 95th percentile. And class 3 is greater than 140% of the 95th percentile for age and sex. And on the next slide, we will look at the specific codes for the classes. This slide provides the specific codes related to obesity class. There are no instructional notes or coding guidelines expressly within these codes. So when a type of diabetes, such as obesity due to MC4R pathway, is documented with a specific class, both codes should be reported. If the BMI is also documented, then this can be assigned as a supplemental code. Additionally, 2 new codes and a revision to the code title for Z68.54 have been added to represent pediatric BMI, as you can see here. And lastly, before we leave the endocrine changes, a new code was added to capture SLC13A5, citrate transporter disorder. This is caused by mutations in the SLC13A5 gene, which is responsible for transporting citrate. This disorder presents with very early onset of multiple types of seizures within the first week of life. Patients have tooth hypoplasia, ataxia, difficult walking or standing, poor communication skills, and below average growth. Patients with this disorder have elevated citrate levels within their cerebral spinal fluid and plasma. And now let's move to changes impacting eating disorders. Several new codes were added to reflect the specifiers and defining features of the new types of eating disorders shown here. The specifiers and defining features are described in the DSM-5 TR that is published by the American Psychiatric Association. For the two types of anorexia nervosa, restricting and binge eating or purging type, along with bulimia nervosa and binge eating disorders, new codes were added to reflect the severity of the condition. The severity is described as mild, moderate, severe, or extreme. An additional code identifying if the condition is in remission has also been added. The in remission code should be used to classify patients with either a partial or full remission. The pattern of the codes for these conditions is reflected in the listing of the binge eating disorder codes, but applies to the anorexia nervosa and bulimia nervosa codes as well. The defining characteristics of severity for each condition varies. For anorexia nervosa, it is based upon body mass index. For bulimia, the severity is based upon the number of inappropriate compensatory behaviors to prevent weight gain, like misuse of laxatives, diuretics, excessive exercise, or self-induced vomiting. Binge eating disorders severity is based upon the number of binge eating episodes per week. The tabular has listed these ranges under each severity as an inclusion note. There are some other changes related to eating disorder codes. The new codes are F50.83 pica in adults, and pica is the persistent eating of non-nutritive, non-food substances for at least a month. The other new code is F50.84 rumination disorder in adults. Code F98.21 had a title revision to add and childhood. Rumination disorder is the repeated regurgitation of food over a period of time, at least 1 month, that cannot be attributed to an associated gastrointestinal or other medical condition. For the codes listed on the slide, new includes notes have been added to indicate that when these disorders are in remission, they are classified to the same code. And now I would like to turn the presentation over to Teresa.
Thank you, June. Welcome, everybody. I'm going to start with discussing epilepsy and neurodevelopmental disorder codes. We have a new subcategory code to classify KCNQ2 related epilepsy, which is G40.84. And as with other epilepsy codes, there are 4 codes for this condition to distinguish between intractable and non-intractable seizures and with and without status epilepticus. KCNQ2 related epilepsy is caused by pathogenic variants in the KCNQ2 gene. It encodes certain forms of self-limited epilepsy or a severe early onset epilepsy. The most common form is the self-limited familial neonatal epilepsy, where the baby will develop seizure onset within the first week of life, but their development is usually normal. Other individuals may have a de novo pathogenic variant, which causes a severe treatment-resistant seizure pattern for the child. The patient will also have a developmental epileptic encephalopathy due to that abnormality in the KCNQ2 gene. Developmental and epileptic encephalopathies, we have a new code at G9342, and DEEs are a group of disorders that are characterized by the early onset, often severe epileptic seizures and EEG abnormalities on the background of a developmental impairment that will tend to worsen as a consequence of the epilepsy over time. DEEs can result from both non-genetic and genetic etiologies. You can see from the slide, the tabular includes notes I put under G9342, which directs you to code also the other neurodevelopmental or epilepsy or intellectual disabilities if documented. Over the past few years, the Coordination and Maintenance Committee has had several requests to classify very specific developmental and epileptic encephalopathies, as well as various neurodevelopmental disorders. So G9342 will help with that. And Z15.1 will also be useful to report with existing codes similar to what's under the code also note for G9342 to represent when the patient has a genetic susceptibility to epilepsy or other neurodevelopmental disorders. Also in the nervous system, we have new codes to capture G90.81 serotonin syndrome. This is a rare but potentially life-threatening condition associated with serotonin toxicity within the central nervous system. Patients can have life-threatening manifestations that include seizures, coma, DIC, ventricular tachycardia, or metabolic acidosis. This can be caused by therapeutic medication use, overdose, or drug interactions. There's instructional notes that I didn't list on the slide, but direct you to code that poisoning first or an adverse effect of the serotonin as appropriate, as well as any other specific manifestations that are documented in the record. And I do want to point out that serotonin syndrome is due to toxicity, so this is different from serotonin withdrawal syndrome. Another index classification to highlight is for thoracic outlet syndrome. They added 3 new subterms there to classify arterial, neurogenic, and venous. So those will have different codes in the future. Now we're going to talk about respiratory conditions. So we have new codes to capture cement and fat pulmonary artery embolisms. And these embolisms are treated differently than embolisms that arise from a blood clot. So what's a cement embolism? This is when PMMA leaks into vessels and ultimately hardens in the pulmonary vasculature. This is a form that occurs if during a vertebroplasty where PMMA is used or cement is used in a hip or knee replacement. This is a mechanical occlusion of the pulmonary arteries that would require an embolectomy. Fat embolisms develop when there are 1 or more droplet particles of fat that enter the bloodstream and embolize through the systemic or pulmonary circulation. Fat emboli can perform when a patient suffers a fracture or multiple severe and complex fractures. Usually these fractures are in the long bones or in the pelvis. These type of emboli can also develop with a patient with severe burns or paniculitis. And they can also develop as a complication of a procedure such as a liposuction, fat grafting, intramedullary rod placement, and even CPR. And the treatment for a fat pulmonary embolism is to provide supportive care like fluid resuscitation, oxygenation, and if needed, ventilation. Here's a look at the new codes, and I also put in 2 revised titles here. There are separate codes for the cement and fat embolism with acute cor pulmonale and without. I also highlighted at I-2693 and 94 that they revised the code titles to specify thrombotic, and I suspect that that was done to help coders differentiate between what code to use for a blood clot embolism and one due to these other entities. It's also interesting to note that I-2609, this code title didn't change, but there's an includes note that they added for other thrombotic pulmonary embolism with acute cor pulmonale. And also pay attention to the code notes. We have to, with the cement embolism, be sure to code the complication, and the fat embolism, if it's due to trauma or due to a procedure, you'll have to pick up a code for that too. So I'm going to start another poll question here with an example for you to code. Patient admitted for routine total hip arthroplasty that was complicated by the development of a pulmonary cement embolism. The pulmonary team was consulted and a plan was made for an emergent thromboembolectomy. What are the correct codes to report for the pulmonary cement embolism? I-2603, B, I-2695, C, T-8481XA and I-2695, and D, T-8481XA. The codes are listed there. Jordan, would you like to launch the poll, please?
Sure thing. All right, the poll has been launched. So give it a few seconds. All right, it's looking like C is the popular vote here.
Yep, and C is correct. Thank you, everybody. You're correct. So in this case, we would pick up the complication of the orthopedic implant that caused the embolism and then add the code for the cement embolism of pulmonary without cor pulmonale. Moving on to nasal valve collapse, we have several new codes here. The nasal valve is the narrowest point of the human airway, and you can see from the picture on the slide that there is an internal nasal valve and an external nasal valve, and ICD differentiates the codes between the site. Collapses in the lateral nasal wall can be due to minor septal deviation, weakened soft tissue, or a malformed lateral crura that impacts nasal airflow. So ICD also differentiates these codes between static and dynamic. So a static nasal valve collapse occurs at rest or not when you're breathing in. It's a narrowing of the nose where that angle between the lateral cartilage and nasal septum is small, reducing the area of the valve, and that results in a constantly narrowed airway due to inflamed tissue, scarring, or a natural deformity. And a dynamic collapse occurs when due to the force that occurs during inspiration. So when you breathe in, the lateral nasal wall is pulled inward by increased pressure. So patients with these types of valve collapses have difficulty in breathing. They don't tolerate exercise well. They have sleep disturbance, and so it really impacts their quality of life. Typically, surgical interventions are done to address the underlying cause. And then of note, I wanted to point out as an includes note, we have nasal valve compromise and nasal valve stenosis. I did want to mention as we were looking and preparing for this, we did not find an index entry for nasal valve stenosis to help direct you here, but just point out that it's classified here. IMO Health has written the Coordination and Maintenance Committee to request that they consider adding an index entry. So we'll see if that shows up later in a maintenance committee meeting in the future. We have new codes, quite an expansion here related to anal rectal and anal rectal fistulas. So I built kind of like a hierarchy so you could see how they split them up. So first is where the location is. And then from the hierarchy, they are differentiating the codes between the location, whether the fistula is simple or complex. So generally, simple fistulas have a single external and internal opening and are associated with no pain or fluctuation to suggest that there's an abscess underneath. According to several clinical guidelines, an anal fistula is considered to be simple when the tract is intrasphincteric or low intrasphincteric. So ICD-10-CM in the tabular, you can see that under the simple, they provide tabular instruction or notes, inclusion notes for low intrasphincteric and superficial fistulas of these three sites. And a complex anal fistula is much more challenging to manage. Treatments for this vary by location and fistula type and can include fistulotomies, endoanal advancement flap, ligation of the intrasphincteric fistula tract, and others. So ICD-10-CM includes extrasphincteric, high intrasphincteric, suprasphincteric, and transsphincteric fistulas as complex. And then these codes are further broken down by temporality. So there's a unique code for an initial fistula of the site, whether that's and that must be a new fistula. Persistent is a chronic fistula, and a recurrent fistula is a fistula that has redeveloped after it was completely healed. So don't mix up that between new, chronic, and persistent. If that fistula recurs after it was in the same site, use the recurrent. Another thing that's interesting is the tabular instructions. There's a code first note to assign a code for chronic Crohn's disease or ulcerative colitis. Many of you might be familiar with the Crohn's and ulcerative colitis codes, which include unique codes such as Crohn's disease with fistula. So now if you have documentation of the fistula with that, you would pick up an additional code to capture the specific location of the fistula and as a supplementary code. So for example, if a patient had Crohn's disease with a complex anal fistula, you would code K50913 for Crohn's disease with fistula and then pick up K60.321. In the digestive system, irritable bowel syndrome unspecified is the revised title. Previously, it said without diarrhea. Last year, many of you might be familiar with all the changes made regarding colon polyps. At that time, there were 4 new codes created to identify family history of various types of colon polyps. So now this year, we're having one more code be introduced at Z8372 for family history of familial adenomatous polyposis. This is a condition that predisposes patients to colon cancer, and they also will develop a large number of colon polyps. So screening needs to be done in younger patients, and that's a useful code to help identify the need for that earlier screening. And we also have an expansion in Z8601 to capture various types of colon polyps as a personal history, and you can see those on the slide. In the integumentary chapter, we have new codes for cholestatic pruritus. Cholestatic pruritus is intense itching on the inside and the outside of the skin, and this is caused by impaired secretion of bile due to liver disease. Often the liver disease can be effectively treated, but patients might have a drug-induced cholestatic pruritus. So you can see from the slide the instructional notes you would pick up where applicable if they have a liver disease or if it was due to an adverse effect of a drug. There are several new codes that were introduced to capture various types of alopecia. In category L66-1, codes have been added to distinguish between classic lichen planopilaris and frontal fibrosing alopecia. Frontal fibrosing alopecia has been traditionally considered a clinical variant of lichen planopilaris, but some advancements in the field, it is now determined to be a unique entity from classic lichen planopilaris. FFA causes permanent hair loss along the frontotemporal scalp and may also include the loss of eyebrows and eyelash hair. Classic lichen planopilaris is a form of primary scarring alopecia, and it presents with smooth white patches of hair loss on the scalp, and these patches often have no visible hair follicle openings. And the last code I want to talk about here is L6681 for central centrifugal cicatricial alopecia. And that's also a primary scarring alopecia. This typically affects women of African ancestry that can result in permanent damage to the hair follicles. And this type of scarring alopecia presents with scarring at the crown of the scalp and radiates out as it spreads. In the musculoskeletal chapter, we have new codes related to intervertebral disc degeneration for the lumbar and lumbosacral regions. The presence of pain is an important factor in clinical decision-making for treatment. So they have split out codes for with discogenic back pain only, with lower extremity pain only, with both discogenic back pain and lower extremity pain, and without mention of pain. Another code in the musculoskeletal system is M6285 for dysfunction of the multifidus muscles of the lumbar region. These muscles are important segmental stabilizers in the spine. This dysfunction is a cause of chronic low back pain, and this dysfunction really is an inhibition of muscle activation that results in a delayed or absent activation during normal tasks, and that can lead to atrophy of the muscle. M659 is an existing code, but it was greatly expanded to capture site and laterality. So shoulder, lower leg, all those codes. So we have quite a few new codes: right shoulder, left shoulder, unspecified shoulder, and the pattern goes on. I didn't reprint all of those on the slide. And then just an interesting, calcaneoapophysitis was reclassified to M92-6 for juvenile osteochondrosis of tarsus. I think it was likely a typo in the index because the old code was to M96.2. We have new codes related to anomalies of the heart valves. The first one, Q2381, is for a bicuspid aortic valve, which is where the aortic valve has 2 leaflets rather than 3. And you can see this code also is used to classify a unicuspid aortic valve as well. The bicuspid aortic valve increases the risk of aortic valve calcification and aortic aneurysm, and it can also lead to aortic regurgitation and stenosis. And from the tabular, you can see the code also notes provided to code also the acquired valve insufficiency and stenosis as they develop. Q2382 is for a congenital mitral valve leaflet, and this cleft is where a slit-like hole or defect in one of the mitral valves is present. We have new codes related to immune checkpoint inhibitors. ICI is a type of monoclonal antibody, and it can be used to treat over 80 various diseases, including 17 types of cancer, Crohn's, and so forth. ICI controls immune system activation and suppression through the surface proteins on T cells, and these surface proteins are the checkpoints. Cancer cells can evade detection by the immune system when these checkpoints on surface proteins are excessively elevated, which is effectively inactivating the immune system. ICI therapy combats this inactivation so that T cells and other immune cells can target the cells properly. ICI is a manufactured drug, which makes it different from other immune effector cell therapy. Immune effector cell therapy, which includes CAR T cell therapy, is customized to each patient. So in CAR T cell therapy, the patient's T cells are harvested, they're genetically modified, and then infused back into patients. But with ICI therapy, the antibodies are just manufactured. So they're not customized to patient. The adverse effects for ICI are significant. So similar to CAR T cell therapy, ICI can lead to cytokine release syndrome. It can also cause myocarditis, colitis, new onset diabetes with ketoacidosis, and various other types of neurological and musculoskeletal conditions. So we have a new code at T45.A to capture poisoning adverse effects under dosing of immune checkpoint inhibitors. And then they also created Z9226 to capture a personal history of ICI therapy. It's been documented that some adverse effects of ICI can turn into long-term chronic conditions or arise after therapy is completed, even months or years later. In the T codes, T81.32 has been expanded to capture the disruption or dehiscence of a gastrointestinal tract anastomosis. We also have a unique code for dehiscence of the abdominal wall muscle or fascia. And then wrapping that out, they have for other specified internal operation wound. I wanted to highlight this coding clinic from 2020, which instructed us at that time to use K9189, which is for other post-procedural disorders of the digestive system, with the previous T8132, which was just disruption of internal operation wound to fully describe the site of that intestinal anastomosis dehiscence. And so with the new code T81320, that describes the GI tract anastomosis, it will no longer be necessary to use K9189 to further describe where that is, since the code says it in the title. For SDOH, Z59.7 was split into two codes to classify insufficient health insurance coverage and insufficient welfare support. Welfare support can include different types of assistance programs outside of insurance coverage. Healthy People 2030 has several objectives related to improving the proportion of people with some form of health or dental insurance and reducing the number of people under 65 who are uninsured. So many of you are aware lack of insurance does affect patients' access to care and preventative services. So this will be important to pick up as we work to track and improve health for all. Other new codes include Kleefstra syndrome, which is another type of neurodevelopmental disorder classified in the Q codes, R4185. Anosognosia is a type of neuropsychiatric condition in which patients are insistent that they do not have a severe illness, and this is distinct from psychological denial. Patients with this condition are neurologically incapable of perceiving loss of impaired neurologic or neuropsychological function. And the last code we want to cover today is E51A for Encounter for Sepsis Aftercare. This is for use in long-term care environments such as post-acute care, home health, which are essential providers for patients that are discharged home following sepsis. Sepsis survivors have a high readmission risk due to post-acute complications and late effects of sepsis after discharge. So you can't use the sepsis codes in post-acute setting. So this code will be very beneficial to help properly classify and describe the patient population in order to hopefully improve outcomes through best practice recommendations, optimize care coordination, and so forth going in the future. The last thing I want to highlight before I turn it over to Dr. Glasgow is some changes. The Medicare code editor is deactivating the sex conflict edit as of 10/1/2024. And these edits were originally created to detect inconsistencies between a patient's sex and any diagnosis or procedure on the patient's record. So for example, if you had a male patient with cervical cancer, which would be a female diagnosis, that would create an edit. These flags are no longer included within the Medicare code editor. At IMO Health, we were leveraging these flags to support search filtering functionality within our precise problem terminology. And IMO Health has decided to continue to support these sex conflict edits on ICD-10-CM codes in order to maintain our search filtering. For non-binary patients, IMO Health recommends turning off any search filtering or code edit functionality related to sex flags. And we want you to be aware that these specific flags are based upon the CMS MCE edits for sex conflicts as of April 2024. Going forward in the future, any new codes that would be applicable to search filtering functionality will be reviewed and added by IMO Health in the future, since CMS is no longer providing this information. If you have any further questions about this, please see the detailed information in our release notes. I have the link to that on the slide deck that you'll be receiving later this week, and or you're welcome to contact customer support. And we also wanted to draw your attention to some codes that have been added to the MSDRG complication and comorbid list. They relate to both social determinants of health and pediatric BMI. This isn't the complete list, but these were some interesting. So you can see that CMS is recognizing inadequate housing and housing instability as indicators of increased resource utilization in the acute inpatient hospital setting. So I'm going to turn it over to Dr. Glasgow.
Great. Thank you very much, Teresa. Yeah, so this is the section of the webinar where we go over IMO's calculator changes that we made for this code set update. And to orient you here, when we say calculator, we're talking about the prompts that IMO Health provides to help users get to a specific ICD-10-CM code. So if you're an IMO Health user, you might call these prompts modifiers, you might call them qualifiers. They're basically prompts for problem list items and visit diagnosis lists to get to a specific ICD-10-CM code. So this year we only had changes to 9 starting points here, and there's the list there. I'm actually going to go over all of them because there are relatively few. So I will go ahead and show you the first one, anemia. As mentioned earlier, the only addition here is the Fanconi anemia. Since it's a type of bone marrow failure anemia, you can choose bone marrow failure in the very first anemia type group, and it'll be one of the values you can choose in the bone marrow failure anemia type. The next one is degeneration of intervertebral disc. As mentioned, there are these pain characterization details that are now active for both lumbar and lumbosacral. So those are for distinguishing between more of a lower extremity pain and then versus the pain that actually originates right in the intervertebral disc itself. They've discovered that is a type of pain that can be involved in back pain. All right, moving on to eating disorder. Now you can see the 2 new types, the pica in adult and the rumination disorder in adult. And you can also see this whole new group that captures the severity and whether it's in remission. Again, it's only selectable with the restricting type anorexia nervosa, the binge eating purging, bulimia nervosa, and binge eating disorder. Now, encephalopathy is actually an entirely new prompt area for us as of June 2024. So some of you may not have seen this yet. For some of you, it'll be new when you load the regulatory update. So this is actually the very first version of this whole concept area, but you can see that brand new specific code for developmental and epileptic encephalopathy is there in the calculator. Again, if you're using an older version than June 2024, you won't see any prompts for encephalopathy. All right, yeah, epilepsy. There's that new KCNQ2 related flavor, and you do need to select intractability and status epilepticus details for that new type. And lymphoma, it's a pretty big change, a lot of new codes. It really surfaces in our calculator as the addition of these 2 new values in the topmost type detail. The subtypes that you can see in my screenshot below, those those all have an in remission variation now. So you'll be able to choose all those details if you choose the in remission choice here at that top level differentiation. The remission codes don't capture the body site, and you'll see that reflected in the calculator when you go to use that. All right, so let's look at obesity. There's that new MC4R pathway type. Now, folks who have used our obesity calculator in the past to know that we have captured class for a really long time in our obesity calculator, because we know that a lot of clinicians think about obesity by class. And so now ICD-10 matches our existing obesity prompts. So that's great. We didn't actually have to make any change in the appearance of our calculator. The codes under those concepts have changed to use the new codes. And then the other big change you can see in the calculator content itself is those new definitions for the pediatric BMI percentile classifications, which are a little more cumbersome to say, but they're more detailed and they match the current clinical thinking about pediatric BMI and obesity classifications. All right, pulmonary embolism. There's our two new types, and you do need to supply the detail about whether acute cor pulmonale is present or not for the two new types. All right, and then the last item is pre-symptomatic type 1 diabetes mellitus. This is actually a new calculator area. It's a new starting point, and it is really unusual for us to add a whole new area in response to a regulatory update. But since this is type 1 diabetes, we felt like it was significant. We did think about trying to build it into our existing main diabetes mellitus calculator, which is already very, very large. And we decided that since this is actually it's kind of pre-diabetes, it's pre-symptomatic type 1 diabetes, users are likely to search for pre-symptomatic and then be prompted for these two stages that are pre-symptomatic. Once you get to stage 3, you are symptomatic. So it's not a big concept area. It's quite straightforward, but we really hope that users find it useful to have this prompt here to remind them to capture the stage of the pre-symptomatic type 1 diabetes. Okay, that is it for our content, and I will turn it back over to our moderators.
Here's our references just for you all to note later on if you wanted to access the proposal information from the NCHS or you wanted to actually view the actual code files. And we also, for the Medicare code editor change, we released also included the IPPS final rule. So June, we're going to turn it over for questions now, if we have any.
Yes. And just as a reminder, if you have questions, please type them in the chat and we are here to answer them. And there are a couple questions. The first one is there a pre-symptomatic type 2 DM similar to type 1? No, the codes, as you can see, that were requested and will become effective in October are related to type 1. And that is based on a lot of the various research and following along of patients from over their time and starting to see the patterns of how the type 1 diabetes has developed. So the new codes and the new modifier that Dr. Glasgow covered are all in support of type 1.
And just to help add on to that, pre-diabetes is classified in the index to R73.03, which is an existing longstanding that you would use for type 2. Next question. Do we have any recommendations for the best way to document SDOH codes? I find providers just listing SDOH codes in the A&P, but hard to determine how they impact the visit, management, and risk.
It's a great question. That is where, working with your providers to identify that impact to the the actual management or that current encounter is really important. So that is one recommendation, is to continue to work with your providers to have them capture how those SDOH areas and elements are impacting the management along the lines that, I don't know, Dr. Glasgow, from a clinician's perspective, if you have additional insight around the documentation for those
Sure.
conditions.
Yeah, and I would comment that it really is sort of an emerging practice to document SDOH. The most straightforward thing to do is to add items to the problem list, and they'll end up on the visit diagnosis list. Sort of from a coding habits standpoint, that's a sound way to do it. But, what's emerging is that there can be some sensitivities involved. Some of the descriptions of the SDOH codes can be seen as kind of stigmatizing. So there has to be care taken. And I would say it really feels like we're still, as healthcare providers in the US, we're still figuring out the best way to record that data, which does have a lot of health impact on a very overarching sense.
Thank you. The next question was, there's no new changes for chapters 14 and 15, and there are no new codes for genital urinary system or obstetrics this time around. And then I think the next question is for Dr. Glasgow. Is there a reason IMO chose to go with diabetes stage 1, 2, and unspecified as opposed to stage 1, 2, and 3 naming that appears in the literature?
Yes, our calculator follows ICD-10-CM because its intent is to aid in documenting in such a way as to get to the most specific ICD-10-CM code. So that's why you'll not find 3 in our calculator.
And if you can reference back to the earlier slides around that stage 3 as being identified as being captured as the type 1 diabetes without complication currently. That's just showing the progression from pre-symptomatic in stage 3, where the patients then become symptomatic as well.
Thank you. The next question is, will 3M encoders also make the changes with deleting error messages when coding gender-specific codes? IMO Health cannot respond to that. You'll have to check with 3M regarding that. I would suspect they will, but I can't address that. June, this one's for you. Regarding the poll question for hypoglycemia, would the proper codes have been E11649 and E16.82? Both answers had E16649.
The correct answer was D, which I'm going to go back.
You want me to back up there quick?
Yes, that was the 2 questions.
Yeah, well, way back there. Yeah. Hopefully that helps.
Yes, the correct answer was D with those. Yep. So that you would want to have the type 2 and then identify the level 2 because the physician had documented the hypoglycemia as a level 2. So yes.
The next question is, should the SDOH codes be added to prepare screening to capture appropriately?
That is something that Prepare would need to address, that IMO Health cannot really answer that, as they own their screening questionnaire.
And the next question, the diabetes coding clinic changed in August. Now it cannot be presumed that the doctor must document the linkage. I will take a look at that after the call. I don't have the coding clinic here right now, but I can review it and we can send a response. And then the next one, diagnosis with consistent with are not coded in outpatient. Or maybe you're talking about the probable diagnosis potentially?
Instead of establishing, if that,
If you want to add more, we'll be happy to follow up with you if you want to add a little bit more to the question there so we can help you out. Are there any new HCC diagnoses for 2025?
so what will happen is now that the code changes that have been published, they're finalized, the processes for evaluating which of those codes will become HCCs will occur between now and when CMS would actually publish which of the new codes would fall into various HCC categories. So it's too soon for to make that determination, but they are working on that process for that evaluation of the new codes.
Oh, and then I see what your question is now from the earlier about the consistent with. So you're talking about this particular example we have where we use the words consistent with level 2 hypoglycemia. So yeah, you would have to validate that as a confirmed diagnosis in the outpatient setting. Yeah. Well, Jordan, it looks like we've got through all the questions. Do you want to?
Amazing. Thank you, ladies, for a great discussion. And thank you, everyone who tuned in. I know your day is busy, so thank you for spending your hour with us. Like I mentioned before, a certificate of attendance, the copy of the slides, and a recording will be sent to you this week. So stay tuned for that and look it out in your email inbox. And then if you have any questions regarding anything support related, email our customer support team at customersupport@IMO Health team or IMOHealth.com, excuse me. And if you have any questions regarding our solutions, email our sales at sales@IMOHealth.com. Thank you so much for attending, and I hope you have a great rest of your day.